Good morning. We'll have a short discussion about the dry socket. Before coming into the topic, dry socket is the most important complications of the surgery. So just remember the few authors' name. In 1896, Crawford is the one who first described the dry socket. Byrne labeled this complication as a fibrolytic alveolitis. It exhibits the exposed bone that is not covered by a blood clot or healing epithelium and exists inside or around the perimeter of the socket or alveolus for the days after the extraction procedure. There are various synonyms are there for the dry socket, which includes alveolar osteitis, localized osteitis, postoperative alveolitis, alveolegia, alveolitis sicca dolorosa, septic socket, necrotic socket, localized osteomyelitis, fibrinolytic alveolitis. So just remember, there are various synonyms are available for dry sockets. These are the few. Coming into the definitions, one should know that the days, the complication which develops after the extraction is 3 days following the extraction. It's nothing but it's a partial or total disintegration of the blood clot which is present within the alveolar socket, may or may not be associated with the halitosis. Coming into the incidence, 3 to 4% will occur following routine dental extractions, 1 to 45% after the removal of mandibular third molars, 25 to 30% after the removal of impacted mandibular third molars. It occurs 10 times more frequently following the removal of third molars than from all other locations. The ratios, the women are most prone to develop dry socket because of the presence of hormones, which causes the fibrinolysis process compared to that of the male. Onset, it mostly begins on 1 to 3 days following extractions. Within a week, between 95 and 100% of all the cases, the patient will develop dry socket. The duration of dry sockets varies to some degree. Only depends upon how far the severity of the disease, and it usually will ranges from 5 to 10 days. Just remember, the onset will be within 3 days and the duration will be 5 to 10 days. Just remember these numbers. What are the possible etiology associated with dry socket, which includes oral microorganisms, difficulty and trauma during surgery, mandibular third molar extractions, roots or the bone fragments remaining in the wound, systemic diseases, excessive irrigation or curettage as smoking, physical dislodgement of the clot, contraceptives, local perfusion, and anesthesia. So the ultimate concept to begin every etiology is that they're all associated with the disintegration of the blood clot. So just remember, the concept of the dry socket is that it develops due to the partial or complete disintegration of the blood clot. Coming to the pathogenesis, so according to the Byrne's hypothesis, we have to remember the Byrne is the one who gave the hypothesis for the dry socket. According to him, trauma or infection which causes the inflammation of the bone, and as a result, there will be a release of tissue activators, which converts the plasminogen into plasmin, which in turn converts fibrinogen into fibrin, leads to the dissolution of blood clot. So one should know what is the mechanisms behind it. As I told that there are two activators plays very important role in it. Remember the name of those activators, the direct activators and the indirect activators. Direct activators includes urokinase and the tissue activators. Indirect activators includes streptokinase and the tissue kinase. These are the activators. The direct one which indirectly convert plasminogen to plasmin, whereas the indirect one, they are convert proactivators to activator enzyme, which in turn convert plasminogen to plasmin. This plasmin in turn converts fibrinogen to fibrin. As a result of it, there occurs the lysis of the blood clot. The signs and the symptoms. Usually the patient will have a tender which become more intense after 72 hours of the post-extractions. It radiates towards the ipsilateral ear, which is nothing but towards the same side of the ear, temporal region or the eye. Clinically, the patient will present with a bare bone. One can able to appreciate this as a bare bone where the patient present to us with a bare bone. Sometimes the patient will have a regional lymphadenopathy, which is nothing but if the dry socket is presented in the 3-6 region. Just imagine if it is present 3-6 region, the patient sometimes may present with the left submandibular lymph node enlargement. That is called the regional lymphadenopathy. Unpleasant taste, which is nothing but occasionally will occur. Also, that patient will have a trismus since it's an infection which causes the restricted mouth opening for the patient. What are the causes of the pain? It includes presence in the formation of the kinin locally in the socket. Just remember the cause of the pain is a kinin because this kinin activates the primary afferent nerves which may have already been pre-sensitized by the other inflammatory mediators and allergenic substances. Even in the concentration as low as 1 nanogram per milliliter of the kinin is sufficient to produce a pain in case of patient presence with the dry socket. What are the factors which influence the healing? So these are the general factors which determines the healing for the patient. It includes infection, size of the wound, blood supply, resting of the part, foreign bodies, general condition of the patient. Coming to the prophylactic management, it includes non-pharmacological and the pharmacological preventive measures. Non-pharmacological measures includes, just remember the highlighted words, use of the good quality and current preoperative radiographs, careful planning of surgery, use of good surgical principles. Extraction should be performed with a minimum amount of trauma and the maximum amount of care. Confirm the presence of blood clots subsequent to the extractions. Coming to the pharmacological measures, antibacterial agents, antiseptic agents, and the lavages, antifibrinolytic agents, steroidal and anti-inflammatory agents, abundant dressings, and the clot supporting agents should be given to the patient. So coming to a few antibacterial agents, the penicillin, clindamycin, erythromycin, and metronidazole, or a local application of tetracycline, either in the form of a powder or in the form of aqueous suspension, gauze, drain, and gel form sponges show promising result in reducing the incidence of alveolar osteitis, which is nothing but dry socket. Pre or post-operative use of chlorhexidine mouth rinse significantly reduce the incidence of dry socket after the extraction of mandibular third molars. Eugenol acts as an abundant. Commercially available dressing is alveolar gel, which contains eugenol, butamen, and iodoform. It has to be replaced every 2 days because that it will itself turn as a source of an infection. The topical application of hydrocortisone and oxytetracycline mixtures has also shown a decreased incidence of dry socket. The tranexamic acid have been reported to be used to prevent the incidence of alveolar osteitis because it's an antifibrinolytic agent which prevent the conversion of fibrinogen to fibrin. As a result of it, it will prevent the lysis of the blood clot. LLT is applied after the irrigation of a socket with a continuous mode of diode laser irradiation. Just remember, there is a laser irradiation can also prevent a dry socket. It has to be used at the nanometer of 808 and 100 M volt and 60 seconds. It has to be applied in the region where the dry socket is present. Use of polylactic acid granules, Axel, topical hemostatic agents they are on, and oxidized cellulose foam shows a reduced incidence of alveolar osteitis. PRP and the PRF, which is nothing but platelet-rich plasmin and the platelet-rich fibrin, can also be used. Dextromar showed a significantly faster pain relief and decreases the incidence of alveolar osteitis. Just remember the few antibacterial agents and the antifibrinolytic agents like tranexamic acid and the dressing agents like alveolar gel and the local hemostatic agents and the laser therapies and then painkillers. These are all used in order to reduce the incidence of the dry socket. Coming to the non-dressing management, remove any suture to allow adequate exposure of extraction socket. Irrigate the socket with isotonic saline gently, careful suctioning of all the excess irrigation. Do not attempt to curate the socket. Prescription of potent oral analgesics, and the patient is given with a plastic syringe with a curved tip for home irrigation with a chlorhexidine solution. So the main theme of the treatment is in order to increase the blood supply in that region in order to prevent the infection. So remove and allow the healing to take place and do not curate, and provided that provide any of the supportive measures like analgesic and an anti-inflammatory in order to reduce the pain for the patient and inflammation for the patient. Surgical management, under the block anesthesia, the sharp margins fat has to be trimmed, rounded, any foreign bodies presence but thoroughly removed. Detached gingival margins also to be scraped. Desired medications as well as should be prescribed to the patients. Precautions. Patients must not only without a pain, but the main theme of the management of the dry socket is that it has to support the psychology of the patient. So remember a few words: dry socket, which is nothing but an alveolar osteitis. There are few synonyms are available for the dry socket, as I mentioned in the previous slide. Just remember the synonyms. And the name of the author who first described and the author who gave the complication as fibrinolytic alveolitis is in burns. And remember the burns hypothesis, and remember the onset and the duration, the incidence of dry socket, and male the will have a less incidence compared to that of the female because of the presence of hormone like estrogen. And 45% it associated with the third molar extraction, especially the mandibular third molar extraction. It will last for 5 to 10 days. Duration is 3 days. Thus, remember the etiology. All these etiology will result in the conversion of fibrinogen to fibrin, which in turn causes the lysis of the blood clot. And this is a mechanism which a flow chart shows the mechanism how the dry socket is developed, and what are the signs and symptoms, and the substance which causes the pain, and what are the factors influence healing, what are the prophylactic management, non-pharmacological and pharmacological, and these are the few pharmacological management, and non-dressing management, and the surgical management. So these are all the important points for you people to crack the MCQs which will come in the NEET exams. Thank you.